This is a panel discussion featuring Dr. Michael Tedaldi, Scott Baker, Marc Mertz, and Dave Francis, followed by an audience Q&A. Audience members are not shown on screen. Questions are asked using a microphone or read aloud by the moderator, Deborah Velosin.
If everybody can take a seat, it is a little after 5:30 and we want to get started. If you could find your seats. And while you are sitting, my name is Deborah Velosin and I'm the Director of Patient and Community Experience. And in a few minutes, I'm going to introduce our board president, but I do want to go over a few items like I do before every town hall. On your seat is a flyer of the bios of our panelists, and there's also a Kaweah Health notepad, and then there's a question card. So after our panelists introduce themselves, we will be doing a live Q&A session. And Lizette and I will be walking around with a microphone where you will get to ask your question to the panel. But if you aren't comfortable asking your question, you can just slip it to us and we will ask it for you. And so that will be in our Q&A session. So Kaweah Health, it is our desire to be transparent. And that is why we hold these town halls, so that you can address our leadership. And but I also want to remind you, and on the back of the Q&A card is just a reminder, in everything that we do, we ask that we are respectful and that we honor each other. And if you have a story or if you have a patient experience concern, maybe it's something that happened to you or one of your family members, please do not say names. And if you want us to dive into that situation deeper, you can talk to me or Lizette personally, and we will make sure we get that concern in front of leadership. So it is my great pleasure to introduce Dave Francis. He is the president of the Kaweah Health Board of Directors, and he represents Zone 4. And he's been on the board since 2018, and he oversees several board committees, which include the Community-Based Planning, Finance, Property Services and Acquisitions, the Governance and Legislative Affairs Committee, Information Systems, and Marketing and Community Relations. He's also a former school superintendent and has served on several community boards. Dave.
Thank you for that thundering round of applause. All right, it's a great pleasure to have you here tonight on the first of our town halls. We're going to try and do a few more of these as the year goes on, and this one happens to be in my zone, and that's why you're stuck with me as the host. But it's my pleasure certainly to be here, and I'd like to recognize in the back row on the right side over there, it looks like a rogues gallery, but it is all the rest of my board colleagues, Dean Levitin, Michael Amos, Jonah Shingle, and Armando Murrieta. And it's great to have you guys here, so thank you. A couple of executive team members that are here, Jag Bath over on the corner over there standing up, and Doug Leeper trying to be inconspicuous back in the back. It's always good when Doug does that. We also have Tom Rayner sitting here, who's is our former COO, has been retired for a couple of years, but it's really good to see him back with us. Just want to say a couple of things. Deb mentioned that I've been on the board for 9 years. And it's been an incredible pleasure to me to do that. I serve the community in as many ways as I can. I'm also on the Turning Point board, and Turning Point of Central California. And I'm also on the church board at St. Paul's Anglican, and I've been on several other boards around town. And it's a great pleasure for me to be involved with Kaweah Health. This is an organization that I didn't initially think about ever being on this board, but Harry Tao asked me to consider it, and I'm grateful for that because I've learned so much about this organization and how important it is to our community and how important all of you and the rest of our community are to us at Kaweah Health. So at this point, I'm going to invite our panel members to speak. I'm going to start with our CEO, Mr. Marc Mertz. Sitting next to Marc is Scott Baker, our Interim Chief Nursing Officer, and at the end is Dr. Michael Tedaldi. And this panel, and I guess I just found out I'm sitting in a chair too, so I guess you could ask me questions based on the board. So because we're running a little bit late, we're going to get started, and so I'm going to turn it over to Marc.
Thank you, Dave. You can definitely hear me. First of all, I just want to thank everyone for coming tonight. Kaweah Health is a public healthcare district. We belong to this community, and we exist solely to improve the health of this community. And we take that responsibility very seriously. We constantly seek input and feedback from those that we serve, and so events like this are important to us. And we appreciate you giving your time to be here with us tonight to learn more about Kaweah and to share your feedback and your questions with us. So thank you. On December 22nd, I became just the 5th CEO in Kaweah Health's 65-year history. Being selected for this position has been the greatest honor of my professional career. Having worked at Kaweah for nearly 8 years prior to being selected, I came into the role with my eyes wide open to the challenges that hospitals are facing, not just here in Visalia or the Valley or California, but really across the United States. Hospitals across the country are contending with massive reductions to the funding for Medi-Cal, a shortage of nurses, rapidly rising costs, and a shortage of physicians. Here in California, our challenges are even greater, with unfunded mandates related to seismic construction standards and a $25 an hour minimum wage for all healthcare employees. Not to mention state budget deficits that limit payments to our Medi-Cal program, which happens to cover 62% of the residents of Tulare County. So given all of these challenges that hospitals are facing, why did I want to be the next CEO at Kaweah Health? It's because I knew that this is an amazing organization. We are not a perfect organization, but I would suggest that none are. But we are dedicated to continuous improvement on our journey to becoming a world-class healthcare system. Our 5,300 employees and our 700 medical staff providers are committed to providing high-quality healthcare services every day. Just as importantly, we strive to bring compassion to every one of our interactions with our patients and their family. We're committed to treating every patient as if they are our friends, our neighbors, and our family. And in many cases, they happen to be just exactly that. There's no secret that hospitals and health systems have struggled following the pandemic and following major legislative changes at the federal and state levels. At Kaweah, we do have a lot of work to do to regain the strength that we enjoyed for decades. But great things are happening here at Kaweah Health, and I'd like to share a few of those with you tonight. So Kaweah Health's fiscal year runs from July 1st through June 30 every year. So we're about 9 months through our current fiscal year. And I'm happy to report that through those 9 months, we have a positive bottom line of $5 million. And that's actually better than we had anticipated for this year. This also comes at a time where more than 50% of the hospitals in California are losing money. While $5 million is a lot of money to you and us, or to you and I, a healthcare system of our size, we actually have to generate more than that to really be able to invest in the facilities, the capital, the other resources that we need to be successful. So we're very happy to be in the black with a positive margin of $5 million. We're working hard to get it in an even stronger position, and we're moving in the right direction. I also want to take a few moments to highlight a very successful federal survey that we recently had. Every hospital that participates in the Medicare and Medicaid program is subject to a comprehensive survey every 3 years. So we had the Joint Commission arrive the last week of February for our survey. 11 surveyors spent the week pouring over every aspect of Kaweah Health. We had nurses, a physician, engineers, and other staff spent 5 days looking at everything we do, including interviewing patients, interviewing staff, observing surgeries, inspecting personnel records, reviewing medical staff records, inspecting every one of our buildings, and even more. And I'm proud to report that we passed with flying colors. There were no high-level findings. Now, I mentioned that every hospital goes through these surveys. More than half of those hospitals that are surveyed have at least one high-risk finding. We had none. And considering the size of Kaweah, we're a very large hospital, a very large health system, it's even more significant for us not to have a high-risk finding. So I'm incredibly proud of the work that our staff and our medical staff did. We had a little fun this week celebrating with free food trucks at all of our campuses to thank our employees and our physicians for the great work that they did. Kaweah Health is committed to investing in our employees and our community. When we, like hospitals across the country, faced a shortage of nurses, we took action. We expanded our partnerships with local nursing schools, including COS, Carrington, West Hills, and others. But we also started our own nursing school. Working with a private college called Unitec, we created a bachelor's degree program right here at Kaweah. Our employees can apply for the program, and if they're selected, they go to school right here at Kaweah in Visalia. They continue to work part-time, they receive full-time benefits, and Kaweah subsidizes the tuition. It's a very grueling and challenging 3 years, but in the end, students graduate with a bachelor's degree and are registered nurses. We were thrilled in January to graduate our first cohort of 13 new nurses. We celebrated at the Fox Theater, and on April 10th, we'll do it again with our second cohort with 25 new nurses. These are staff members who had served as LVNs, CNAs, ED techs, office assistants, security guards, and other positions, so they're now able to further their careers, stay close to home, and then benefit Kaweah Health in our community. I'm also proud of our graduate medical education programs. This June, we will graduate 44 new physicians, many of which will remain here in the Valley to practice. And then just a couple of weeks later, we will welcome 53 new residents and fellows who will begin training in family medicine, psychiatry, emergency medicine, surgery, anesthesia, transitional year, and child and adolescent psychiatry. Since we started our GME program, we have graduated nearly 400 new physicians, more than 1/3 of which have remained in the Valley to practice medicine. Kaweah is committed to building these pipelines for both new nurses and new physicians. But we're also starting even earlier, working with local students to help expose them to careers in healthcare. In 2025, we had more than 800 volunteers donate more than 51,000 hours of service to Kaweah Health. 500 of those volunteers were high school students from Tulare and Kings counties. And we are seeing the inspirational power of this program as kids who have volunteered at Kaweah in the past are now applying to and being accepted in a medical school. I'll close my comments where I started tonight with Kaweah Health's commitment to improving the health of our community. The Valley has about half as many physicians as we need, and I'm happy to report that we're making progress in some of our most underserved specialties. We have recently received signed agreements with a new urologist, gastroenterologist, and a neurologist. And this week, we welcomed a new cardiothoracic surgeon, Dr. Tran, who started on Wednesday. It will help keep more heart surgery patients closer to home for their care. And more physicians are on their way with a strong point to us, and I'm going to introduce Scott Baker.
Good evening. Let me see if I take this. Thank you for having me. I'm Scott Baker. I'm the Interim Chief Nursing Officer for the hospital. I actually was asked to step into the role on December 10th, right before Marc stepped into the CEO role. Was very excited to do so and help lead nursing in the hospital. I actually have been with Kaweah for 15 months now. I came out in November of 2024 as the Interim Director of Emergency and Trauma. Fell in love with Kaweah and the community right away, and by the end of last year, I was talked into signing on. Didn't really have to talk me into signing on. I really wanted to be here. So I tell everybody, I love this hospital, I love this community, and I think there's a lot of great things happening here. Wanted to give an update on some of the nursing things we're working on. As Marc mentioned, and I'm sure all of you know, that nursing has been a challenge to fill positions here. When me and the group Rhonda back there and a bunch of us came on as travelers to help out, we had about 250 to 300 nursing positions open. The challenge is finding skilled, experienced nurses. And so we looked within our community with all the schools, CSU, Unitec, Porterville, lots of different schools, and so we started hiring within the community. Prior to coming on, there was some hiring being done outside of the area, but as we looked at what's in our community, these are nurses that live in the community, that have family in the community, that have family that work at the hospital, and take care of all of you. So we've now hired, we have about 60 RN positions left. So it's very exciting to say we only have 60 with the graduating class coming up 25. We're going to keep recruiting those and filling those positions. Our education program for our new grads is quite robust. So they come in, they get time on the floor. In the ER, it's about 14 weeks. On the med-surg units, 8 to 10 weeks. And they go through a really extensive program with education. I think Marc and I were last month meeting to have a graduation of the new nurses that go through these orientations. And we graduated 60 new nurses about a month ago. And we have another 60 or 70 that will be graduating next month. So all these are nurses that have been here, they've been working as new grads, but they go through this extra program of 1 class a month for the 6 months, gaining those basic skills. And so when they're done with that, they are engaged on the floor and ready to start. And so I think I'm about to run out of time. The next question is, what am I most excited about with Kaweah? So I think first is Marc coming on board and the executive team he's building. You know, as he's hiring new people and the executive team is new, those are fresh ideas that come in. So I can't wait to see how this executive team moves the hospital forward with care and really taking care of the community. The other thing I'm excited about is all of our nursing director positions have been filled. We have some highly skilled nursing directors, and all of our manager positions have been filled. So that allows us to better educate and manage the staff, help them to better take care of the patients. And one thing we're driving right now is all of our clinical quality. So our, I'm going to say it in clinical words, but our Foley catheter infections, our central line infections, those that we're really trying to reduce and make sure we're taking good care of our patients and keeping them well when they go home. So thank you for letting me be here.
Hi everybody, my name is Mike Tedaldi. I'm one of the hospitalists here. You know, I spend most of my day talking to people, but I still get pretty nervous when I'm in front of big crowds. So if it's okay with you guys, can I tell a doctor joke first? And then I promise I never miss a chance to have a laugh at my colleagues' expense. And it also ties into a little bit what I do as an internal medicine doc. Okay, so the joke goes like this. It's a dinner party, and there's an internal medicine doc, a neurologist, and a trauma surgeon talking to someone. And all of a sudden, that person passes out. And the neurologist goes, oh my God, I wonder what's happening. The baroreceptors are misfiring. Think of all the cool pathophysiology that's going on. The surgeon kind of looks at him and goes, he'll be okay. And then the internal medicine doc revives the patient. So, yeah, I thought it was. So, yes, as a hospitalist, I spend most of my day reviving patients who are really sick. And you know, the hospitalist, or at least the discipline of hospital medicine, is kind of fairly new to the scene. About 25 years ago, you know, if you were sick enough to be admitted to the hospital, your primary care doc would come in and see you. But guess what happened? Baby boomers got older, and the population exploded, and we just couldn't do it. Couldn't do it anymore. It was too much for a doc to see patients in the hospital and keeping up with the pace of things there and maintaining an outpatient clinic. So thus, the hospitalist was born. And at Kaweah, at least with the group that I'm part of, Valley Hospitalist Group, we are zonal. So that means if you are ever sick enough to be in the hospital, the floor that you get assigned to has a hospitalist assigned to you. So we are kind of like the quarterbacks of care. Right? We come in, we see you every day, we're there all the time. If a nurse has a question or concern, we're there to answer it, give family updates. So that's all we do. That is my practice. And a little bit about my role as the Vice Chief of Staff. So something I'm fairly new to is kind of giving me like that 30,000-foot view of hospital operations. So I get to kind of be the bridge, the liaison between the medical staff and the administration, and overseeing things like quality, patient and safety. So just to mention briefly some of the kind of cool projects that I get to be involved in, things like the Code Crimson. So an initiative for when a lady comes in, peripartum hemorrhage, right, gives birth and all of a sudden bleeding. It can lose a lot of blood very quickly. How do we mobilize our resources, anesthesiologists, OB, get the OR up and ready to take care of that patient as fast as possible? Other things that I get to be involved in are, you know, quality metrics, making sure our heart failure patients get to go home or should go home on all the right medicines. COPD patients, making sure you're on the right inhalers and things like that. So that's a little bit of my role as Vice Chief of Staff. I will say questions that you guys have. The harder the questions are, you can pitch them fast in my head, the more fun it will be for me, and I think the more you guys will get out of it.
Deborah Volosyn.
Okay, so now it's time for Q&A. Are you guys ready? Okay, so if anybody would like to address the panel, ask a question, Lisette and I will be running around with the mic. Who would like to go first? Okay.
Audience member.
I have a question about the immediate jeopardy citations that I know Kaweah Health has received in the last couple of years, I think like 4, maybe since 2020, I want to say 10, which are, I mean, as you know, extremely serious citations, probably one of the most serious citations that a hospital can receive. So pains that there's been like so many, especially 4 in the last 2 years, as early as 2025. What's the plan? What's been put in place to make sure those types of things, which is negligence that happened, doesn't happen?
Marc Mertz.
I'll start, and then I think the nurse and the doctor probably will have contributions to it. So the question was related to immediate jeopardy. So immediate jeopardy is an unexpected event that occurs in the hospital of a very significant nature. These can happen for a variety of reasons. In some cases, we self-report them to the state. We tell them what happened. In other cases, it might be reported by an employee or by a patient. One immediate jeopardy is too many. So we've had entirely too many at Kaweah Health. And we take each and every one of them extremely seriously, I can tell you. And we are committed to not just understanding what happened, but preventing that from ever happening again. And so we spend a significant amount of time and energy and effort really breaking down everything that occurred leading up to that event to understand at which step could we have done something differently to have avoided it. And that's all part of the plan of correction that we do submit. We've also implemented daily safety huddles. So every single day, we have leaders from across the organization come together and we review kind of near misses, things that we identify where a staff just raised their hand and said, this didn't go exactly as we expected. Maybe it never reached the patient. Maybe no one was harmed. In most cases, nobody was. But it was just something that didn't go as expected. And so we spend time as a group with the leadership talking about, again, what happened, how we avoided from happening before. And so those are happening every single day to ensure that we're doing the basics, providing a safe, high-quality environment every day. And that's what we owe to our community.
Scott Baker.
Thank you for the question, and I'll piggyback off what Marc said. So from a nursing standpoint, when we have an IJ or any kind of deficiency, when the state or Joint Commission comes in, we really take those seriously. And part of the process, we look at process improvement, how to keep those from happening moving forward. So I know that prior to I've arrived, there were some IJs related to some things in the ED. And so we had to react pretty quickly. The executive team brought a few of us on to really address some of those issues. And it took us about 4 weeks, and we restructured the whole flow of the ER so that there weren't 100 patients waiting in the waiting room. Now, that's ER. We also look about on the floor. So if we have someone had a large wound or an injury, a fall, we're constantly looking at those practices and trying to make sure that we're doing what's right based on the evidence-based practice that's out there. So as we look at falls and HAPIs, which are the wounds, HODIs and CLABSIs, which are infections in the central lines and in the Foley's, those we're constantly looked at. So when we get those deficiencies, IJs are, of course, the worst because it's immediate jeopardy, but they drive us to really looking at our quality and how we fix those issues to get better care.
Dr. Tedaldi.
Yeah, tough question. You took me up on my offer, so thank you. Yeah, so I think number one, at least from a physician standpoint, is accountability. It's a very hard thing as a physician to look something in the face when a bad outcome happens. But that's the first step, because without that, you can't get better. But at least from my standpoint, and what I try to tell other physicians that get into these situations is we have to think of a way to make healthcare fly. What do I mean by that? So the airplane industry, they have a lot of checks and balances to make sure that you get to your destination safely, right? Because if one plane falls out of the sky every day, nobody will fly. And medical errors account for about one plane crashing every day. So we have to try to build protocols, checks and balance systems, so that we don't have these things happen. Timeouts before patients go to the operating room. Order sets that have very specific checks and balances, but that are also involve nursing communication between physicians. So it's each immediate jeopardy has its own nuances, and we do root cause analysis to try to figure out what happened. Was it, the Swiss cheese model? Just a bunch of things went wrong all at the same time, and how do we prevent that from happening again? But yeah, it can be a tough thing. But the first step is, of course, accountability. Yeah.
Audience member.
Good evening. My question is, having been a visitor recently to the emergency room, what are your plans for taking your urgent cares and making them have longer hours, perhaps relieving the emergency room a teeny tiny bit?
Marc Mertz.
Yeah, it's a great question. So for those of you who don't know, we do operate currently 2 urgent care centers, one on Court Street and one on the north side of town off of Demery. These are really important facilities to do exactly what this question kind of speaks to. Is they are a fantastic alternative to the emergency department for many minor illnesses and injuries. So we've recently significantly expanded the provider staffing in those 2 urgent cares. It's a lot of nurse practitioners and physician assistants working under the leadership of a physician. But we've increased the number of physicians and providers that we have at those locations. We are actively looking at the hours of operation for both of those locations to do exactly that. And then as we create that capacity, we want to do a better job of educating the community on what's appropriate to go to the ED and what's appropriate to go to the urgent care. We've run a number of social media campaigns in the past, and I think we'll be doing that again. We just wanted to make sure that we had the increased capacity, both providers and eventually additional hours. So it's a great question. It's something we're definitely looking at doing. We're also considering additional urgent care locations. And so we monitor the volume of patients that come to the emergency department. And last year we set a record with 101,000 visits in our emergency department. I would say probably 20%, maybe 25% of those patients did not need emergency room level of care that could have been treated somewhere else. So we're able to actually look at the coding for those visits, the level 4 and 5 level visits, and we can say, where do those individuals live? And then we look at putting a new urgent care at that location to hopefully encourage those folks to visit that and keep the emergency room for more of those traumas and significant injuries. Scott, anything to add on ED?
Scott Baker.
I just want to say I hope your visit was okay. First of all.
Audience member.
Some ideas, actually, about how to make things a little bit easier for very nervous, upset, scared visitors.
Scott Baker.
I will listen. We'll meet afterwards. So part of this flow that we redesigned was looking at all those level 4s and 5s. So when you rate in an ER on a what they call a ESI, Emergency Severity Index scale, you start with your 1s, it goes to a 5. Your 1 is a patient that's not breathing, that needs immediate help. Your 4s and 5s are those that are easy, that are urgent care visits. So when we came into this ED and we were brought out to really look at all the problems they were having with the IJs and the citations, and looking at flow, we looked at those 4s and 5s and we redesigned the front end process to be linear so that those patients are seen a little faster and out of there so that we can move them through and really manage the 1s, 2s, and the 3s that have chest pains and abdominal pains. So there has been work done. I want to listen and see what other suggestions you have. It's about changing and adapting every day. And so definitely open to anything that the community has to say so we can help it get better.
Deborah Velosa.
Scott, this might be a great time to put in a plug for our Emergency Department Advisory Council that meets once a month, and somebody with a lot of great ideas would be a great member on that council, so.
Yes, so one of the, I will say, one of the big reasons that I fell in love with Kaweah was in my second month, I was invited to what we call EDAC, and it's the Emergency Department Advisory Committee. And the energy that comes from that committee, I think the first meeting we had, I was given 5 or 10 minutes to talk, and 50 minutes later, I was still talking. So highly engaged community. And again, like I said, when I started, that's what I like about this community. In my 31 years of nursing and multiple communities that I've lived in, I have never seen the tight-knit community here that's involved in the hospital and what we're doing. So love to hear from everybody. The emergency department, or the EDAC committee, definitely, if you want to join, it's great. We love hearing all the ideas they bring forward. Paladin.
Deborah Velosa.
Thank you, we have a question.
Audience member.
Good evening. Thank you for taking my question. See, my name is Eric Quirk. I am a retired physician, and I'm locally here growing citrus and invested in this community. I'm also an instructor for Kaweah Health Lifestyle Fitness Center in Qigong. I noticed that Kaweah has a chronic disease management center as well as a medically based fitness center, including PT and exercise prescription. These are both very good assets that Kaweah has. However, I also noticed that we do not seem to have a TCM, which is traditional Chinese modality, such as acupuncture, herbs, Qigong, Tai Chi, that only exists in the community wellness program. It is not integrated into the clinical care. My question is this: number one, is Kaweah exploring any integrating TCM therapy into a unified clinical model where physicians can prescribe them as part of medical care beyond individual practitioners offering acupuncture in private offices? Number two is that if not, will Kaweah be open to examining the UCLA model developed over 30 years by Dr. K. Kit Hugh, who is a Wallace Enberg Fellow Chair. Number two, is also a founder of one of the nation's first integrative medicine center, and he's also a fellow of the American College of Physicians and a WHO, this World Health Organization advisor since 1990. They have published a peer-reviewed data that shows 30 days readmission rate from 33% to 5%. That is a 86% reduction, as well as pain-related readmission down from 32 to 3.4%, which is a 89% reduction. So, in closing, this is the kind of result that will make a meaningful difference for patients, finances, and this community. Kaweah has the assets, and UCLA has the blueprint. Thank you.
Marc Mertz.
Thank you for the question, and thank you for the work that you do in the community. Answer the first question, no, we're not currently evaluating such a program, but the answer to number two is, I think we'd certainly be open to considering that. We do have a new leader who's responsible for all of our outpatient facilities, and so we would love to get some information and contact information, and we can look into that. I don't know if Dr. Tedaldi any clinical perspective on it, or
Dr. Tedaldi.
There's a lot of truth to what you say. You are imagining this to be done in an outpatient clinic, I would assume. Is that you are imagining that these things, like traditional medicine or like acupuncture and stuff like that, is happening in an outpatient setting? Is that?
Yeah, as far as I know, currently Kaweah does not have.
Audience member.
As far as I know, Kaweah does not have integrated TCM involved in it, whereby all the doctors can prescribe these sort of things to the general public.
Dr. Tedaldi.
Yeah. not something that I routinely do in my practice, but if you build it, they will come. I think if you have an outpatient setting like that, or if maybe you yourself, take up that initiative and offer it to the local primary care doctors, I can assure you, you would get referrals. Maybe that would be the easier way to do it.
Okay.
Audience member.
Marc, I'm now a community, no longer within the healthcare system, and I am approached by members of the medical staff that have expressed some concern about the progress being made at Kaweah Health. Have you done a physician satisfaction survey, and if so, what has the score been? And have you received any of this feedback at all?
Marc Mertz.
Yeah, I don't know that it's fair that former executives get to ask questions. We do a physician engagement survey every 2 years. So every 2 years, we do a comprehensive survey of all of our employees on, I think, 37 different questions about, essentially their satisfaction at work. At the same time, we do a similar survey with physicians. So we do look at it. The scores are disappointing, which, frankly, was not a surprise, I don't think, to me or to other executives here. And so, yes, I was aware of many of the concerns of the medical staff. That was a significant point of conversation during my interview process. And frankly, as I interviewed with the board, because they did do a national search, as they should have done for the position, as I ranked my priorities for Kaweah Health, the first one on the list was improving the relationships that we have with our physician partners. All of the things that we want to do, improving the safety and quality of all of our services, whether it's in the hospital or clinics, improving the service that people have, the experience that they have when they come to see us. All of those things are entirely dependent upon our partnership with our medical staff and our physician partners. I also interviewed with the medical staff, including Dr. Tedaldi here at the end of the table. There was probably 25 physicians, and that was a very engaged conversation. Dr. Tedaldi had some excellent questions and some very honest and questions. And since then, I meet with physicians every single day, and I tell the medical staff I'll meet with any doctor, anytime, any place. It's mornings, evenings, lunch, dinners, the whole thing, and so we've got work to do. We've got work to do to repair, expand, enhance the relationships we have with our physicians, and I'm entirely committed to doing so.
Audience member.
My question is also regarding the ER. I don't know what the laws are or what happens, but let's say when you're in the ER, I unfortunately visited the ER April of last year and then February of this year, and the wait times are unforgivable. I mean, and you can look around and I'm like, okay, I am not a doctor, and that person has a cold. A person has the flu, and it's during the day. Are they not allowed to say, hey, you need to go to urgent care?
Scott
Not
Baker.
allowed.
So the federal law EMTALA, so the Emergency Management, that's Active Labor Treatment, it's the EMTALA law. It regulates for pregnancies and for ER visits. You can't turn a patient away without having a medical screening exam, meaning that a physician has to evaluate the individual and assure that they don't have an emergent need at that time. There's some hospitals back in Florida that will do the MSE and then discharge you. Kaweah is not one of those. We do the MSE, and if you're there for a sore throat, we're going to see you, treat you, and discharge you. I would say you said last February, or this February, last April. So last April, you hit us just as we adjusted the flow. So it was learning and winter volumes. This February was winter volumes. We had the highest ER volume in any of the Februaries that we've had. So with flu and all the individuals sick and the holding in the ED, because the hospital's filled, we need a new hospital. It's hard when you have 411 beds in the facility that are constantly full, and you have multiple admits coming in through the ED. We have a 74-bed ER. And when you're holding 55 patients, That's 55 of your 74 rooms tied up. And that's not inclusive of your trauma rooms that you can't put patients in because you have to have those ready for traumas and codes. So completely understand it is EMTALA and it is the law that no matter who comes in, we see them. If we had an urgent care next door and you presented to the ER, we still have to see you and do that medical screening exam before we can take you next door.
Audience members.
Do you have plans then at urgent cares to provide x-rays or MRIs and things like that? That way you don't have to go to the ER and wait forever. Because I did go to the urgent care thinking I could get an x-ray there. And then after I waited and got in, oh no, you have to go to the ER.
Marc Mertz.
You went to one of our urgent cares and they wouldn't do the x-ray there? 'Cause we have x-rays at both
Went
of
to
our
the one on
facilities.
Port.
They've got 2 x-ray machines there.
Though they sent me to the ER, they said, you gotta go to the ER. After I waited and got in, they
Yeah.
told me I had to go to the ER.
We'll connect with you afterwards and get some more information, follow up with you, because that shouldn't have happened.
Okay, then I waited at the ER for 8 hours.
Audience member.
I had just kind of 2 questions, kind of a future strategy. One would be, are we looking at opportunity for an OB/GYN residency in the future? And the other would just be maybe sharing an update on meeting seismic requirements going forward.
Marc Mertz.
2 excellent questions. So actually, today at our executive team, we talked a little bit about an OB residency. So residencies are training programs for physicians after they've graduated medical school. So to become a doctor, you go to undergraduate for 4 years, you go to medical school for 4 years, and you're a doctor, but you can't really practice because you don't have a specialty. You go on to residency programs. In this case, you go on to additional training to become an OB/GYN physician. We currently have 130 residency slots. These are the 6 residency programs we have. Then we also have a fellowship. That's how we get to above 130 fellowship. If you're not tired of school after residency, you get to go to fellowship to become even more trained, or more highly trained. But those 130 slots, we receive funding from the federal government to train those physicians. We're at our cap. We can't add more residents on top of that. So we would have to repurpose existing residency slots that we have in those programs that I mentioned during my opening to move those over to OB/GYN. We'd have to get approval from CMS and from ACGME, which governs all of GME. But we are actually looking at it. We're also actively looking at potential avenues to expand our GME program. There's 2 potential ways we might do that. Hospitals with GME programs can elect for a rural designation. Even though the hospital is not in a rural area, we're still able to elect this rural designation, which changes our funding a bit, but also allows us to temporarily reopen our slots, that cap on slots. So we could pursue OB/GYN. OB/GYN, neurology, and potentially internal medicine are the top 3 priorities that we have. So it's absolutely something that we're looking at. We're also considering, are there opportunities to partner with other organizations that have maybe available GME slots that we might be able to work with. Sierra View is an example. We have a very close relationship with Sierra View. They have a GME program. Their cap is not closed. They still have an opportunity to expand, and so that's a conversation that we've very informally had. I mean, don't call Sierra View and ask if we're doing it, but I have talked with them very informally about that. We're very open to partnerships to do things like that. Seismic was your second question. So after the Northridge earthquake of 1994, the state of California passed Senate Bill 1953, which created seismic requirements for hospitals across the entire state. Those requirements are exactly the same whether you're in Visalia or 20 feet from the San Andreas Fault. So they don't consider the risk of the location, but they essentially provide different statuses for buildings. Because our Middle King building opened in 1969 and opened before 1972, it automatically received a very low rating on those seismic standards. So essentially today, it cannot be used for inpatient care beyond 2030. That's concerning. 40% of the hospitals in California are in the same boat, cannot be used today beyond 2030 because of the seismic requirement. So there's been a lot of discussion at the state level to try and either extend that deadline or change the requirements. We have recently filed an application with the state and the department that oversees hospital buildings in this code, we were allowed to do computer simulation modeling to show exactly how that building would perform in the event, the unlikely event, frankly, in this community, an unlikely event of a severe earthquake, and it performed extremely well. And so the state allowed us to submit that application to get a higher rating that would allow us to use that building indefinitely. So we're hoping that we get that because the building is safe, and we are in a relatively or very low seismic risk area. That being said, the building opened in 1969. If you've been in there, the rooms are small. There are single rooms, which is rare back in the 60s, but they're very small. It's not an ideal hospital to work in or to be seen in, and so we do need to replace that building. Before the pandemic occurred, we actually had plans. Many of you probably participated in a lot of the public discussions that we had about what would a new hospital look like. We had essentially designs for an 8 to 10 story building that would go right next to the obsequious wing. It would increase the number of beds. We have 206 in Mineral King. It would have at least 240 beds, new pharmacy, new dietary, new operating rooms, new pre and post surgery spaces. At that point, we estimated it would cost about $750 million to $830 million. That cost has gone up significantly. You imagine what things cost in 2019 versus today. So we might be looking at $850, $950 million to replace that building. Frankly, with what we went through during the pandemic, there's no way that we could fund that kind of a capital project today. Obviously, in the past, we've gone out to the community for general obligation bonds, property taxes, to raise funds. Personally, I'm not confident that that's the path forward to raise that kind of money. And so we're actively looking at, one, can we get a little bit of reprieve from the 2030 deadline that's over our head? But then longer term, we know we need to, and we want to replace that building. Not just, because the other one's old and we want a new one, but think about recruiting the best staff and keeping the best staff. Think about recruiting new physicians, the best physicians who want to come and stay here. Having a modern facility will help us do that. So we're committed to long-term to getting there. We're working with our representatives, all the time. Is there legislation that can help? Is there, low interest or no interest funding through the state that can help us get there? We're looking at a whole variety of different avenues to help replace that parking building. Sorry if that was long-winded.
Audience member.
What are the most common issues that you're facing at the hospital as far as types of disease or types of patient care that you're providing? And what could or should we do as a community to try and improve the health and improve so they don't get there?
Scott Baker.
Okay, so we see everything. I think cardiac care, there's a lot of work happening around cardiac care right now. Ahim, I can't pronounce his last name, is the Director of Cardiovascular Service. He reports to JAG. This guy's brilliant. And so he's bringing on a lot of services currently that are working, and he's working with our CVIC, our Critical Care Services Director, to really look and see how we partner to make sure that those patients are receiving the best care. So I think always, we all hear about cardiac care. Stroke's the other one. So, stroke identification and early activation, saves lives. So I think stroke and cardiac are probably two of our biggest issues here. But you have the others. The basic medical complaints, abdominal pain, gastric surgeries, traumas. We see a lot of traumas. Remember, I want to say it's 3,500 traumas a year, which is quite a bit. It's a little hard to prevent in the community. But we take care of those patients very well. So I think cardiac and stroke are probably two of the biggest ones that we can really impact in the community. The last one I would say, which is huge, is sepsis. Sepsis is so critical to timely fluids and getting the patient in to be seen. A huge mortality rate, so a lot of patients die from sepsis. So I think that's one thing we can identify in the community with fever and sick and elevated heart rate and lower blood pressure, what's happening, diaphoresis or sweating, how the patients or families get those patients to us as quickly as possible. Because just like stroke, time is brain, time is muscle in the heart, and time is critical for organ function within sepsis. So those are my three top. Did that answer it?
Dave Francis.
The other issue that we face is the chronic nature of disease within the community, diabetes rates, heart failure, various kinds of things that reflect lifestyles. And I think one of the issues is how do you help people understand healthier ways of living and things that they can do to change their own behaviors relative to the things that are happening in their body that's going to get them eventually. And when you look at the chronic number of people who have, the number of people who have chronic diseases, when we're looking at our hospital-acquired infections and all the things that we have to report to the federal and state government relative to patient care, almost all of those are affected at a great level by those chronic diseases that people have had build up in them over the years. So the issue is, as a community and us as a hospital group, is how do we help people help themselves in terms of better ways of taking care of themselves? How do you promote healthier diets and all the sort of things that people do to keep themselves healthier? But to me, the layer that is underneath all of the things that Scott's talking about are all those chronic disease issues that you have that force people to make some choices or not make them. And if they don't make them, or if they don't understand how to make them, then that creates an issue that's even greater. You look at our population health programs and what they're doing with people around the basic conditions of health, that the things that happen that are undermining people's health all the time that they may not know about, those are really issues around things that we're trying to do to help people help themselves become better patients and be just better human beings health-wise. And I know in my own case, I've got some kidney issues, so I'm now drinking gallons of water and no Pepsi. And I'm already getting some better results. I happen to be a diabetic, and I have been for 30 years, but it's about learning how to take care of the conditions you have, and we have so many people who don't understand what the conditions are and what they need to do to take care of it. And I think that is an underlying thing that within the community we need to attack at a larger level than just at the hospital.
Audience member.
Agreed, and it's such a challenge. I would just like to very briefly just share my family's recent experiences. We've been here our whole lives. We've had many experiences, not all positive. But recently, my 94-year-old dad was taken by ambulance after a fall and got him settled in, and my brother was with me. My brother was born one of the first babies born in 1969, so it really happened for a long time. But anyway, and he walked out and he came back, and I said, "What is wrong with you?" And then he proceeded to pass out, fall on me, and I'm yelling for help, not knowing there was already the ED staff running to get him. And so they got him in settled, and I was checking both of them, and then they whisked him away again because his blood pressure bottomed out again. So he was taken to the more critical area. So he took one of those beds that was probably waiting for somebody else, but he kind of took priority at the time. He eventually, my brother did get admitted, and my 94-year-old dad eventually did get discharged. So that was a very long day. But what I'm very thankful for, a little bit more recently, I'm not sure, I hope you all know about our CSU, our crisis, stable, thank you, for young people up through 21. That's been a passion of mine, but I didn't know our family was going to be needing that. And I had a young family member, and a 20, and behavior had just kind of changed gradually, and angry, and not eating, working out obsessively, and just not wanting to take care of themselves. And we knew there was help needed, didn't really know where to go. And I called there just mostly for resources so we could get started somehow. But after listening, they really encouraged that he come visit them right then. And when I told his dad was a little leery because I'm the only one he trusts. I don't want to break that trust. What if he's scared about that? And when he did walk in, the first thing he did say was, "Is this where they're going to tell me I'm crazy?" And it turned out to be such a blessing. They were so wonderful. He wound up getting, the care and evaluation he needed, medication, and was within 24 hours, it was a completely different story. And if we didn't have that unit, that might not have been such a good ending to that. There's still work to do with the follow-up, especially if you have private insurance when it comes to mental health, and that's a big need. But if you're not familiar with the CSU, please get familiar with it, because it is a blessing to our community. Thank you.
Marc Mertz.
Yeah, thank you for sharing that. I probably should have mentioned the Crisis Stabilization Unit in my opening comments, but this opened in December, and this is a 24-hour-a-day, 7-day-a-week facility. Essentially, it's an emergency department for mental health crisis, and it's just for adolescents and youth 21 and younger. I don't know of any other facility in the state that is open 24 hours a day, 7 days a week to provide these types of services to the community. And so we were, thrilled to be able to bring this to Tulare County. It was a partnership with the County of Tulare. Kaweah and the county applied jointly for a grant from the state. We did receive the money and redeveloped the old Boy Scouts building down on 3rd Avenue, right next to Proteus, not too far from the Oval. For those of you familiar, not too far from here. I was actually there today. Congressman Jim Costa was in town and wanted to visit the CSU he'd heard about, and also Dr. Corey Jakes. You may have heard of Dr. Corey Jakes. He's the medical director for that facility. He's also the program director for our Child and Adolescent Psychiatry Fellowship. So I mentioned fellowships are beyond residency. So we train psychiatrists here, and then they go on to additional 2 years of training to become fellows in child and adolescent psychiatry. But Dr. Corey Jakes was recently recognized as the Red Cross of the Central Valley's Healthcare Hero of the Year for the work that he's doing with youth. He's the most passionate and compassionate physician, sorry, Dr. Tedaldi, that I know in the community. He was born to do what he's doing, which is taking care of kids in their crisis. And I encourage you all, if you come across a family member, someone at church, or a youth that you're aware of that's having any kind of crisis, I encourage you to do exactly what this family did: is call them, just stop in and visit. It's just a place of healing and recovery. So, and if they can't help you, they'll find you the resources. So, Crisis Stabilization Unit, 3rd Avenue downtown.
Sam Logan over here. This one I'll direct to Marc, and maybe the whole board. Kaweah has a very, I'd say, great hospice process. My wife and I used it for the duration of her time, and this was some 7 years ago. Lately, there's been a lot of negative press on hospice units in Minnesota and in Southern California, as far as the government or the state of California through Medi-Cal. Could you talk to me, is that an issue in our county? I know there are hospices in Visalia, at least I think there are, as it relates to competing with our firm, our Kaweah Health operations. Thank you.
Yes, Sam, I appreciate the question. So we do have an adult and a pediatric hospice program. We also operate the Open Arms House, which is a residential hospice with 6 beds, just a fantastic facility. So I'm not personally aware of any of the sort of fraud and abuse locally with hospice programs. I do have a good friend who runs a hospice in Los Angeles, and for a decade he's been telling me how hard it is to compete because he operates kind of as you're supposed to, and he's getting kind of beat up by some of the other hospices. So, if there's waste in healthcare, we want to see that removed. If there's fraud, we want to see that taken out. That just means there's more money for those of us who are doing it the right way. So I don't know if anyone else is familiar with any other hospice activity.
Dr. Tedaldi.
So Dr. Ryan Howard is a palliative care doctor here. I don't know if you've interacted with him, but when we enroll somebody in hospice, or when we as physicians think about someone's hospice eligibility, really we're thinking about 6 months or less, to live, right? The Medicare fraud I think you're alluding to is folks that do not meet that criteria, that do not have a terminal diagnosis, being enrolled in hospice, on the hospice rather. So I know Dr. Howard and his team are pretty strict with us, so but that's not to say if some folks are feeling like they don't want to be treated anymore, we can take a different approach, right? If they're maybe not eligible for hospice, we can do something called home-based palliative care, right? Where we're just treating their symptoms. We're focusing on the quality of life, not doing something to increase the quantity of their life. But yeah, it's pretty strict in the hospital about who we can enroll.
Audience member.
Jim Young here. I have 3 compliments, actually. Maybe this will make your day.
Scott Baker.
That's what they are, Tim.
I understand. The first one, I want to say, I'm in the VA healthcare system, and I want to thank you for being a provider in that system. I really appreciate it. And I know there's many fellows that do, and I thank you very much. I know it covers a lot of areas in Kaweah Health, but thank you for that. The second compliment is about urgent care myself this morning. So I fell yesterday. Fortunately, I'm okay. I hit pretty hard, a couple of bruises, and my ribs I wasn't sure about. So I went to urgent care on Court Street this morning. Really didn't wait too terribly long. I think I saw a doctor within 20 minutes or so, 30 minutes. It was early this morning. And I was interested in an x-ray, just kind of abundance of caution. And so they did. Gave me an x-ray, and he told me, he was a big, tall fella, and he said to me, look, there's nothing you can do about ribs. You just got to gut it out. And I said, well, okay, but I'd still like to know if they're broken or not. Okay. So I got an x-ray, and I asked the technician who did it, what do you think? And she said, well, I've got to have someone read it, but it looks okay, so fine. So I went back and I waited to hear about the results, and I decided I didn't want to wait any longer. So I left and asked them to just simply call me. And they haven't done that yet. But I figure I'll give them a couple of days, So that's compliment 2. Urgent care works, and I appreciate it. And I actually submitted my VA health card, and it seemed to work just fine. The third compliment is a friend of ours. This is current time, now about 2 weeks ago. 96-year-old woman fell, broke her leg, went to the emergency room, was there something as, I think they've said like 30 hours, but despite the length of time, they say she got wonderful care. It was just a matter of not being able to find a room to go to. And so she was cared for, subsequently went up to a room. Through that process, they evaluated her, which runs to Dave's observation. She's been in the gym for 50 years, fairly fit woman, and they had evaluated, decided she could have surgery to repair this leg. And that happened about a week ago, I think, and she stayed in the hospital. Well, the hospital stay was, I guess, about 2 weeks, which included the surgery, and she's now out at Cypress Center and going through rehab, and she expects to do fine, 96 years old. So it made me think, I know I don't look like it, but I do go to the gym, and I'm thinking, by God, I'm going to keep going. So those are 3 compliments for you.
Thank you.
Audience member.
Hi, I just wanted to compliment a place that I've been volunteering since November, the Open Arms. And I had no idea that, I just thought it was a home for elderly. And it's a hospice care. And I've been there since November. There's 6 beds available. I volunteer once a week. And I have my little cheat book in my pocket. And I write down their names of what rooms they're in, because they don't put names on them. And it's so sad. cross it off, cross it off, cross it off, and then making me pay for it. And I tell you, that is the most awesome place. And I was a preschool teacher, and I thought, I have to do something else. I can't handle being home. I thought, why not take care of the elderly? And that has been a blessing. And I'm really looking for a job if anybody has it. Just to see how they're taken care of. It is a wonderful place.
Marc Mertz.
Yeah, she's speaking about the Ruth Wood Open Arms House. And so this is the six-bedroom residential hospice that I mentioned before. So this was operated by the community for a number of years. And it just fell on challenges with the pandemic and other, the challenges of running such a facility. So they actually approached us a number of years ago, and we were honored to be able to kind of bring the Open Arms House into the Kaweah structure. And so we do operate it, but I want to give a big plug to our hospice foundation. So Kaweah has two foundations, both separate 501c3 nonprofits. One is the hospital foundation, benefits the hospital, as you might expect, but there's a separate hospice foundation with a community board that is passionate and extremely active in support of hospice more broadly, but very specifically the Open Arms House. It is a wonderful facility with a staff that is unbelievable. Dr. Ryan Howard, that Dr. Tedaldi mentioned, is, again, you might give a running to Dr. Jakes as one of the more compassionate doctors. Dr. Tedaldi is a very close third. But thank you for your volunteering there. We're proud of the service that provides to our community. It's a fantastic facility, and I encourage anyone to consider the Hospice Foundation if you're looking for a place to donate money.
Audience member.
Hello, Rosalinda Alexander. I'm here to represent Assemblywoman Macedo of the 33rd District. She's a state representative. And sitting next to me is Kyle Savage with Senator Grove. Sorry I put you on the spot. But we're both here to support. When I think of Kaweah Health as a constituent, I think great doctors, great care, saved my father's life, my husband's life. Thank you very much. As somebody who's also sat in the ER watching a lot of people come in and out that one feels like maybe this is not the place for you. I'm sitting next to somebody that's in a lot of pain, and I'm struggling watching this, and I see a crowd, wall-to-wall people. Sometimes it looks like a war zone in the waiting room. So I vowed that the next time I had a chance to speak up, I don't know if it's a possibility to do PSAs. I know Kaweah Health has a marketing department, but I think we think that other people know that they should know better about where they should go, but I don't know if it's a possibility for PSAs, both in Spanish and English. These are the reasons you go to the ER. These are the reasons you don't go to the ER. Here are pictures of other places that you can visit. I just think that sometimes we assume people know, and it really is a matter of education. So that's just from me as a constituent, trying to advocate for our people that are in those waiting rooms, waiting 15, 16 hours. My husband had sepsis for 3 weeks, so we were going back to the ER for 15-hour waits, and it was quite ridiculous. So I understand the issue. What I'm saying is public awareness. So thank you.
Marc Mertz.
Yeah, it's a great point, and as I mentioned, we've done campaigns in the past. We kind of put them on pause to increase our capacity, so I think we're in a position now that we can relaunch those. We try to do cute social media campaigns where it says, if you're bitten by a bug, go to urgent care. If you're bitten by a bear, go to ED. So we try and get people's attention. So we'll definitely launch that. There is information on our website, I believe both in English and Spanish, Karen, about exactly this, and these kind of categories of things that you should go to one or the other about, but we could do a better job of promoting that. And just thanks to both of you guys and your representatives, both strong supporters of Kaweah and healthcare in general in California.
Deborah Velosin.
Okay, while we're waiting, we got that. Yeah.
Audience member.
Marc, you had mentioned that Kaweah Delta is now in the black $5 million. Is that for a specific time period? Does that mean all the old debt that was there is no longer there?
Marc Mertz.
So it is from July 1st, 2025 through the end of February 2026. So our March books aren't closed yet. So for those 8 months, we're $5 million positive.
Okay.
We do have, yeah, that's worth.
So there,
worth-
yeah,
worth
no,
cheering
that's
for.
great, that's
It
great.
is.
I just, one time I knew there was, or heard, millions of dollars in debt, so I was wondering, is that gone?
You probably heard millions of dollars in annual losses. We do have, I mean, millions of dollars in debt, but all hospitals or even big businesses, I mean, you balance borrowing versus spending cash. And so we do have, it's over $200 million in debt, but actually, if you look at that compared to the fact that we're a $970 million a year organization, it's actually quite a small amount of debt. But what you'd heard in the past where there were some years following the pandemic where we actually lost money each year. And so, as I mentioned, we're $5 billion to the good this year. We want to make that even higher. Honestly, for an organization of almost $1 billion, we should generate probably $20 to $30 million of profit a year, so we can reinvest in new buildings, new equipment that's very expensive. The other thing that we've been able to do is rebuild what we call our days cash on hand. You'll often hear hospitals talk about days cash on hand. Well, what is that? Days cash on hand is a measure that's commonly used to assess the financial strength of an organization. Essentially, if no more money was coming in, which is not realistic, right? We have money coming in, but money stopped coming in, how many days could we operate with the cash that we have in the bank? It costs more than $2.5 million a day to run Kaweah Health. The magic number is 90 days cash on hand. If you have 90 days cash in the bank, you can run the hospital for 90 days with no more money coming in, then you're essentially a stable hospital. So we did dip below 90 days during the darkest times of the pandemic. Spending $10 million, $20 million, $12 million a month on travel nurses, surgery was shut down, all of those things. We're now over 110 days cash on hand. So we're definitely in a much stronger position. We want to see that continue to build. Essentially, it's like your savings account, right? You spend out of your checking account, you want to have a nice savings account for those rainy days. We're rebuilding our savings account now.
Audience member.
When you talk about net profit, you talked about net profit. Mark, when you talk about net profit, are you talking about net profit or free cash flow?
Marc
It's the
Mertz.
net income, so we're generating more cash than that. So it's $5 million. I mean, adding back depreciation, it's another $20 million.
Deborah Volosyn.
So, Mark, how do we measure quality of care at Kaweah Health, and then how is that information shared with the public?
Marc Mertz.
Wow. So we measure quality in many, 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 many ways. We internally, it's probably hundreds of quality measures that we track across the organization. There's probably about a dozen, maybe 2 dozen that we really focus on at the board level and the executive team level that we're monitoring every single month. It's infection rates, it's readmission rates, it's mortality rates, things like that. A lot of this is tracked and reported publicly. There's organizations like Health Grades and Leapfrog and the federal government that actually publish this data about hospitals. But we're constantly evaluating and measuring the quality scores that we have. We have goals to drive them and improve them every year. We report to the board every single month on those quality measures on the very specific things we're doing to drive it. So those are kind of the quantifiable clinical outcomes. I would also add to it is the compassion that we provide to our patients. I mean, I think that contributes directly to the quality of care that people receive. And so that's something that we're very actively pursuing. It's kind of the science and then the compassion added to it. Dr. Tedaldi?
Yeah. Just kind of, adding what you said, kind of, I'll use a specific example. So when someone comes in with a heart attack, or the medical term for that is a STEMI, there's a national average gold standard that we have to meet, which is door to balloon time. So the time that you come in to the hospital and we identify you as having a heart attack, to the time where you are in the cath lab with a heart doctor fixing the blockages in your heart is 90 minutes, right? So we are doing pretty darn well actually on that measure. So quality there is great. For things like heart failure, we look at how soon are you coming back to the hospital if you've been discharged, within 30 days. or also mortality. How many of our heart failure patients, pass away in the hospital? So it's really disease specific. To use another example, stroke. How fast are we able to get you to the CT scan, or how fast are we able to get you the medications that you need to reverse the effects of a stroke? So yeah, it's kind of a loaded question, because it really depends on what the disease process is. And then of course too, I'll say quality is also, did you have a good experience in the hospital? Would you recommend us to your friend? Would you come back and see us again? Would you go to one of our primary care doctors? I think we can't overlook that as a quality metric in and of itself too.
Scott Baker.
And we also track quality, so we have monthly QCOM and a patient safety meeting where all the nursing directors or radiology directors, they have to come and present their data based on how we're doing a specific metric. So like I said, HAPIs, which are your wounds, CAUTIs, CLABSIs, those are all tracked from a hospital standpoint, and we present those monthly with the chief medical officer, the chief executive officer, to sort of track and trend where we are with those quality measures. And an example, Dr. Tedaldi was talking about stroke, and so probably about 3 months ago, we noticed we have a stroke committee, and we noticed our times weren't that great. And so when we walked the process, we found that there was a delay in the patient arriving in the ER and getting a stroke alert called. And that was running about 22 minutes from that time. Should be less than 10. So we restructured our process, worked with the physicians, and now we're calling those in less than 10 minutes, which then allows us to get them to CAT scan. And we've got our new teleneurology program where you put the cart up to the patient, the neurologist signs on, they're in there looking on the computer, reading the CAT scan in the room, and then they're making that recommendation whether they need the TPA, the blood thinner, to get the clot, or if they need to be transferred out. So all that's quality that we're constantly looking at, because we want to provide the best care to the community.
Deborah Volosyn.
So this question is, how is Kaweah Health partnering with local organizations to address broader health issues like homelessness and mental health? You guys covered the crisis stabilization unit, but when we talk about the high volumes in the ED, the conversation seems to always go to the homeless population because they are frequently in our emergency department. So how is Kaweah partnering with outside organizations or other community organizations to handle that crisis?
Marc Mertz.
Specifically homelessness?
Yeah, because we've covered the mental health.
Probably the best example is our partnership with TC Hope and now CSET, who operates the Navigation Center. So we provide annual funding to that facility. In exchange, we receive, there's a couple rooms that we're able to discharge patients from the ED to the Navigation Center. So if you think about a patient who is homeless, who might have a wound, if you have a home, you might be able to be discharged with a wound because you're going to change it, you're going to clean it, you're in a safe environment. If someone's living at the St. John's River, you can't discharge them with that wound. So we would hold those patients in the ED or even in the hospital. So through this partnership with CSET, TC Hope, we have those rooms where we can discharge that patient directly to that facility, freeing up room in the ED in the hospital. We also have our street medicine program. So street medicine is essentially a volunteer program that's created through Kaweah's GME program, where residents, supervising physicians, and staff actually go out into the community and provide care. And so we raise money from the community that supports that program, which is just fantastic. We're actually in a meeting today looking at greatly expanding the scope and the frequency of the street medicine program, actually going out into the community. We work with Salt Light and work with others to deliver care where people are, whether they're in the ED or whether they're in these other locations.
Audience member.
Really quickly, yeah, just to piggyback off of her question, I know we covered like the mental health crisis, but what about for adults? Like if there was a mental health crisis in someone who was 30 or 35 or 40 or 50. Yeah.
Marc Mertz.
So we actually wanted to open a crisis stabilization unit for adults, but we weren't able to do that. The county has its new behavioral health urgent care. It's opening at the Hillman Complex in Tulare. We also have behavioral health services embedded in all of our rural health clinics. So we have 6 rural health clinics throughout the community. There's therapists and in some cases psychiatrists embedded in all of those clinics. We also opened on Noble, kind of right across 198 from the hospital, our Center for Mental Wellness, where there's counselors available there, and they accept all insurance. Actually, part of the conversation I was having with Dr. Jakes and Jim Costa today was, it's actually interesting that the coverage for mental health isn't where it needs to be, right? And so Dr. Jakes was advocating for parity, so medical services, mental health services. In many ways, Medi-Cal actually provides more mental health services than commercial insurance, which is kind of backwards from what you tend to think about. So that's why we opened the Center for Mental Wellness, which is more oriented to commercial, but we're actively working on it. It's a national issue. It's an issue here in the Valley. We're very fortunate to have our psychiatry residency. Because of that the adult residency and then the child adolescent fellowship, we have more psychiatrists and child adolescent psychiatrists here than a vast majority of communities in California or across the country. So we're fortunate in that regard. We keep, actually our retention rate I mentioned is about 1/3 for our graduating residents. With the child and adolescent fellowship is over 50%. So every year we're graduating 3 new child and adolescent psychiatrists, and they're mostly staying here. I know your question's about adults, but we've got a lot of psychiatrists too.
That's good. That's good.
Scott Baker.
So I'll say that, when an adult's having a crisis, they come to the ER. It's not the best place for an adult in crisis to be, but we're there to make sure they're safe and stabilize them. I'm sure everybody knows we have the psychiatric adult unit at the psychiatric hospital. So we're staffing at an average of 48 patients a day. That we've hired travelers, because Marc wants to get us to 54, and then to a max of 63. The great thing there is that a lot of our mental health patients within the community that are in crisis, we don't have to send them outside of the community. And I've worked at a lot of hospitals and organizations where you're sending these patients 30, 40, 50, sometimes 100 miles away. We do that everywhere I've worked with adolescents. I think the closest is in LA, or I know there's one up in Walnut Creek. And so when you think about your child having to go that far, and how do you as a parent that may not have as much money get up to see them? So it's the same with an adult. Having those resources here, first organization I've ever worked at that has their own psych hospital. And they do a great job over there. So stabilize, treat, and that's a great resource for the community.
Marc Mertz.
I think we need to do a better job of educating the community. And that's something that we meet with the county frequently. The county actually brings together a coalition on mental health a couple times a year. There's probably about 50 different people there. And it's amazing, even to me, to learn about the different services available in Tulare and King County. And so if I'm not aware of it, I know the general community's not. So that's on us, that's on the county, that's on other providers to better educate the community on what is available. It's not all connected as well as it should be, and that's something we can work on too, but I think we need to just better educate folks on what's available.
Dr. Tedaldi.
Is your question specifically about an adult in crisis, or just access in general to mental
Audience
health?
member.
I think it was specifically for adults, just because you guys had talked about the 21 and younger, and so in my head I was like, what about the rest of the people? Because there's people that go through mental health crisis at any age, at any time in their life, and so that was kind of just like my curiosity, what if they don't have insurance, even because there's people in their adult life that don't have health insurance, and so what do you do in that situation? And it probably is like a thing where you're just not aware, we just don't know the services and the things that are available to us.
Dr. Tedaldi.
Okay, I just wanted to-
Yeah.
Audience member.
Marc, at Rotary, I want to say it was 6 or 8 weeks ago, our city planning director came and spoke. Mike, you were there. I don't know if you were there, Marc. But he showed various maps, none of which said let's just stop growth by cutting off the sewer lines, which is a plausible solution. And no, shake your head, this is a plausible solution to this community's problems. But if you are looking at simply the sprawl that was denoted on that map, the city could grow to 200 to 300, let's say 300,000 people. We've attracted the developers from Fresno, not on top of our traditional local building trades developers in the city. Fortunately, I've only had to be hospitalized at Kaweah Delta once. That was in 1963 when it was a small brick building to get my tonsils out. And yeah, I remember when in 69 the new building, which I agree is inadequate. You've got, you know, one way or another, whether you get a size relief or not, it's got to go. But even if you got rid of that building and built a bigger one that was maybe up to standards of the new tower, you're only breaking even. And given the politics in Sacramento, which really makes it very difficult for communities to restrict growth, how are you going to finance what may have to be a doubling or tripling of the size of the hospital over the next 2 decades? Can't you sit down with the city council here in Visalia and board of supervisors and other constituent cities in the district and say, hey, look, if you want new homes, you have a taxing authority. Theoretically, we have a board that is elected by the people to supervise the people's needs. Why don't you just slap large developer fees on the growth in this city and not worry about the big beautiful bill, not worry about a bond issue, and just, you know, pass the cost on to the people who are really impacting the capital needs of this hospital.
Marc Mertz.
There's a lot there, Tom. I'll say that we are looking at all avenues for funding that new tower.
Yeah, but the new tower could bring through maybe.
Well, when we looked at this back 8 years ago, we thought we needed 240 beds to replace the 206. I bet you if we redid that study today, it wouldn't be 240, it might be 260, 280. But the other thing that's occurring, and yes, the community is growing, yes, we're all getting older, but we're doing more and more things to keep people out of hospitals. We're actively pursuing what's called a hospital at home, where for patients who maybe they have an infection or they're recovering from a surgery, can we send them home with 24 hours a day, 7 days a week monitoring? They have a nurse call button that they can hit. They're hooked up to biometrics, and we have doctors and nurses in the command center. They're monitoring those vital signs. If something doesn't look right, we can send someone to their home. We have home visits twice a day. We have home imaging. We have home phlebotomy. We have other services like that. So for those patients who, otherwise are relatively healthy or on their way to recovery, can we keep them at home and not in a hospital? I think you're going to see more and more of that across the country. You're going to see more and more of it here in this community. And hospitals will be really for the truly sick and injured, to the point that, if I were to build a new 280-bed hospital tomorrow, I'd probably build those rooms so they could flip back and forth between medical, surgical, and ICU level beds, because I think in the future, you're going to have sicker patients in the hospital, and those that are in medical surgical beds today are going to be at home. And it's a lot less expensive to roll out a program like I just described than the $3 million or more that it costs to build one single patient room in a hospital.
Okay.
We're going to have to get creative. We're going to have to get creative to fund it.
All right, well, thank you.
Unless you have $800 million.
Deborah Velosa.
Going once? Okay, so we have come to the end of our time, so we want to thank everybody for coming. I also want to point out Leslie, the city manager, is here. Liz on our city council is here, so thank you. And Dave, would you like to wrap this up?
Dave Francis.
It's been a pleasure having all of you here, listening to your comments and your support and your concerns. And believe me, as a board, that we take that very seriously, and we're very, very grateful for the kudos, but also for the concerns and the complaints. So thank you all for coming. It's been a good night. We'll see you next time. Thank you.